Oh, I'm on it. There we go.
Good morning. We'll give everybody about a minute to hop on and then we'll get started. All right, we'll get started. Good morning and welcome to the February 27th meeting of the Patient Protection Commission, and we're going to go ahead and get started. Chair Sexton, I'll hand it over to you.
Thanks so much, Dylan. Good morning, everybody. Welcome to the public meeting of the Patient Protection Commission. My name is Bethany Sexton. I'm chair for the Patient Protection Commission, and I'm going to officially call this meeting to order. Mr. Malmlove, will you please conduct the roll call?
Thank you. Commissioners, please identify if you are present when you hear your name called. I'll start with our voting commissioners. Dr. Jonathan Chastain.
Present.
Dr. Mark Glyman.
Here, present.
Dr. Ikram Khan.
Present.
Ms. Marilyn Kirkpatrick.
Present.
Dr. Andrea Peterson.
Present.
Dr. Adam Porth.
Present.
Dr. Travis Walker.
Present.
And Ms. Bethany Sexton.
Present.
I'll now move on to our non-voting ex officio members. Insurance Commissioner Ned Gaines.
Present.
Director Stacy Weeks.
Present.
And then I believe Courtney Gresh will be attending on behalf of Executive Director Janelle Davis. We'll mark her as here when she arrives. And then we can mark Executive Officer Teresa Karsten as absent excused. Chair, that concludes roll call and we have quorum.
Excellent. Thank you.
The second item on the agenda offers an opportunity for public comment. No action may be taken upon a matter raised under the public comment period unless the matter itself has been specifically included on an agenda as an action item. To provide public comment telephonically, you may join the meeting by dialing 775-321-6111, and when prompted to provide the meeting ID, enter 981-401-478 pound. Please press *5 to raise your hand during the public comment periods to provide your comments. Comments will be limited to 3 minutes per person. Persons making comments will be asked to begin by stating their name for the record and spelling their last name. If you wish to provide public comment and joining by phone, please press *5 to raise your hand. If joining by the computer, use the raised hand icon at the top of the screen. Please, Chair. Shannon.
Good morning. Shannon Sullivan, Shannon Sullivan Figueroa, sorry, long last name. SULLIVAN-FIGUEROA. Okay. Thank you for the opportunity to make a public comment. My name is Shannon Sullivan Figueroa. I am a speech language pathologist and pediatric private practice owner in Northern Nevada. I also serve as the secretary for the Nevada Speech Language Hearing Association, or NSHA. NSHA is making an update today to let the Commission know about our current priorities following the 2025 legislative session. As you may know, the bill we worked on to join the Interstate Compact for licensure for speech pathologists and audiologists was successful. However, at this point, joining the new operational compact system has stalled as the Nevada Board of Examiners for Speech Language Pathology and Audiology is waiting to hear back from the FBI in regard to allowing background checks. NISHA is continuing to request that the Board of Examiners actively versus passively inquire about background checks, both with the Nevada Department of Public Safety and the FBI. NISHA is also continuing advocacy regarding speech swallowing codes that are not being reimbursed through Nevada Medicaid for provider type 34 for therapy. NISHA has been working on these codes since 2023. The following CPT codes are currently not included in the provider type 34 fee schedule. 92612, flexible fiber optic endoscopic evaluation of swallowing or FEES. 92511, nasopharyngoscopy with endoscope. And 31579, diagnostic laryngoscopy with stroboscopy. These codes are included in provider type 20 for physician's fee schedule. NISHA members have reported that physicians in Southern and Northern Nevada are not completing these procedures, which is presenting a barrier to care. This work is within the scope of practice for speech-language pathologists, and private insurance reimburses for these services. NISHA is continuing advocacy for Medicaid pay parity between provider type 34 and provider type 20 and 60. Codes across speech, language, occupational, and physical therapy under provider type 34 are reimbursed on average 10 to 15% lower than the exact same codes in the provider type 20 and provider type 60 fee schedules. For example, 92507 is reimbursed at $73.76 for provider type 20 and 60, but is reimbursed at $63.64 for provider type 34. Provider type 60 covers school-based services. Providers who perform services in the community versus in school settings should be reimbursed with parity, as the training and degree required and care provided are similar, if not more skilled, in the private practice setting. Gaining pay parity would increase services across the state for early intervention in children. NISHA is happy to provide any additional information and look forward to hearing how we can continue to advocate for these changes. Thank you for your time.
Thank you. Is there anyone else wishing to make public comment at this time? Chair, I see no one else wishing to make public comment at this time.
Okay, thank you. Let's move on to item 3, which is to introduce some of new commissioners and returning commissioners. I also just wanted to start with a reminder that the Patient Protection Commission exists to systematically review issues related to the healthcare needs of Nevada residents and the accessibility, affordability, and quality of healthcare. And I'm really excited to join my fellow commissioners and wanted to introduce Miss Marilyn Kirkpatrick. She's a Clark County Commissioner and has been recently reappointed to the PPC. She's representing a not-for-profit hospital in the county of the state that spends the largest amount of money on hospital care for indigent persons. Marilyn, if you wouldn't mind maybe sharing a little bit about your background, that would be great.
Madam Chair, I think you did such a good job. I don't have much to offer. So I'm just glad to be part of this. You know, I served in the legislature for 11 and a half years, and now I serve on the Board of Trustees for our hospital, and I serve as the county commissioner, and I also serve on the health district. So I have a wide range of boots on the ground input from people across the state. And I also sit on NACO and National NACO on their healthcare committees. So thank you.
Well, we're glad to have you back, and thanks for your service. Dr. Andrea Peterson is a pharmacist and has been recently reappointed as well. She is serving as a member with expertise and experience advocating for persons with special healthcare needs, and has education and experience in healthcare. Dr. Peterson, would you mind sharing a little bit about your background as well?
Yeah, thank you. I am also just grateful to be part of this. I am a pharmacist by training, but the majority of my experience was 13 years in the maternal child health area, particularly in NICU, and then also serve as the chair of our Department of Bioethics, Humanism, and Policy in Roseman's College of Medicine. Thank you.
Thanks. And then as I started, I'm Bethany Sexton. I will be serving as your chair for the PPC. I'm member who represents a private not-for-profit health insurer with the highest percentage of insureds in the state who are adversely impacted by social determinants of health. Glad to be returning to the PPC and have enjoyed being here and making sure that we're thinking about all the needs of Nevadans when it comes to healthcare. So my background, I've been at Renown Health for the last 11 years in many different roles, but within the care delivery side. And then for the last 3 years have served as the CEO for Hometown Health. And then recently, as we moved into the joint venture, we'll be establishing Kaiser Permanente here in the state of Nevada, and excited to be serving as the health plan leader for Kaiser Permanente. All right. I also wanted to just take a moment to express sincere appreciation to Dr. Khan. He has served as the chair for a number of years, and just appreciate so much all that he has done for the PPC. And we certainly are building on that strong foundation as we continue to move forward. But thank you so much, Dr. Khan. Truly appreciate you and your service.
It's been my honor to serve the state.
Thank you so much. I also want to take a moment to acknowledge and welcome some of the new staff members that we have that have recently joined the commission. We're pleased to welcome Stephanie Purnell as the PPC's policy analyst. I don't know, Stephanie, are you on the line today? Not.
It's great to be here.
Oh, awesome. And then Alexandra Lopez Duarte as our administrative assistant. Are you on the line?
I am.
Great to have you here as well. And we're so grateful for all their support in helping us do the work of the commission. So thank you. Okay. I think we are ready to approve the meeting minutes from December 12th. The meeting minutes from December were distributed to the commissioners prior to the meeting today for review. Do any of the commissioners have any questions about the meeting minutes or recommended edits?
Yes, Marilyn.
I was just going to say I'm going to abstain because I wasn't an official member for the last meeting, so I'll go ahead and abstain.
I also was not an official member, so I will also abstain. This is Andrea.
Thank you.
Chair
I
Sexton,
move that
this
the
is
minutes be-
Adam.
Go ahead, please.
Adam Porath. I had a chance to review the minutes, and I would move that we approve.
Is there a second?
Second, Dr. Khan for the record.
Thank you. Anyone opposed to approving the minutes? Okay, I will take that as they are approved. Thank you. Okay. You want to walk us through, Mr. Mallow?
Yes. This brings us to agenda item 5, which is discussion and voting for the PPC's vice chair. At this time, I'll open the discussion to Chair Sexton to nominate a person to fill the role.
Thank you so much. I would love to nominate Dr. Peterson if she might be willing to serve in that capacity, and or we could certainly take others who may be interested in the role. But I think, especially given your background and some of the things that I think we have upcoming around maternal child health and other things, you would be a great fit.
Thank you. I would be honored.
Is there any discussion?
I second.
If there is no further discussion, I would like to entertain a motion for Andrea Peterson to serve as vice chair of the PPC for a term of 1 year. Would anyone like to make a motion?
Dr. Glyman, I make a motion.
Is there a second?
Dr. Khan, second.
All in favor, please say aye.
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 Any opposed? Sorry. Any opposed? The motion carries. Congratulations, Andrea,
Thank you.
and thank you.
Thank you.
I believe that moves us on to agenda item 6, a presentation on the perinatal healthcare workforce from Dr. John Packham.
Ellen, can you see my screen presentation?
Yes.
All right. Thanks for the opportunity to present the latest, greatest information on the perinatal health workforce in Nevada. It's good to see some familiar faces on the commission, and wanted just to say that my aim in presenting at this point in the meeting is to hopefully set the table for other individuals speaking to behavioral health issues, to trends in fertility and birth rates and the like, as well as some of the challenges that we face as a state addressing maternal and child health in our state. A good deal of the information I'm going to share with the group today comes from data that my office has collected for the better part of 3 decades. And I've listed some of those resources there. I also wanted to share, and I'm happy to announce the release of the 8th edition of our healthcare careers manual. I've got a truckload of hard copies headed my way, and happy to share that with folks in this group and on the call today. But in the meantime, if you click on that QR code, that will take you to an online interactive version of the careers manual. Again, happy to speak to those at some other day. I thought I'd begin with a couple of definitional matters. I'm taking a very broad view of what constitutes the perinatal healthcare workforce, focusing on that range of health professionals and support staff caring for pregnant individuals and infants from the time of conception through that first year postpartum. Folks might define that a little bit differently, but that's how I'm going to try to frame my discussion today of that workforce, trends, drivers of demand for this workforce, and so forth. What I've observed over particularly the last couple of decades is that workforce includes an increasingly diverse, wide range of multidisciplinary teams, plural sometimes, of that includes but is not limited to licensed medical and nursing clinicians, mental and behavioral and support staff, and an increasingly wide range of allied health workers that play roles in both hospital-based and community-based settings. This is Packham's not completely exhausting list of occupations that fall within that definition that I just shared with you. Many of these will be familiar, but some of these are new to the list. If you compared that set of occupations that we would think of as being in the perinatal health workforce, this list looks very different than it did even as recently as 15 or 20 years ago. So, and I think putting my rural hat on for a moment, we think about how perinatal health care is provided or coordinated in rural and frontier and remote areas of the state. You will see a greater incorporation of many of these types of occupations and positions across the continuum of care. I wanted to begin my discussion of workforce trends in Nevada. I would point out these trends are quite similar to what you're seeing in other U.S. states, particularly states in the western half of the U.S. But these are common trends, and that commonality includes what's driving demand for perinatal healthcare workers. What's interesting, I think, is that this demand, which I would consider increasing across Nevada and other U.S. states, is happening at a time in which we're seeing flat, if not steadily, declining birth rates and fertility rates. There was an article in the New York Times this morning discussing the decline of birth rates across all parts of the country, across all socio-demographic groups, and so forth. Nonetheless, I would argue the demand for perinatal healthcare workers continues to increase. What's driving that, and I think you're going to hear a little bit about this in subsequent presentations, is that pregnancies are getting more complex. There's reasons behind that I'll discuss in a moment. We're also seeing that mental and behavioral health needs are increasing and being recognized, and there's a growing expectation. I think that's a good trend that these need to be dealt with, as well as physical clinical care issues that come with pregnancy and childbirth. I'm also going to speak briefly about what the growth of maternity care deserts in Nevada and elsewhere. Those are some pretty striking trends that I think policymakers are going to have to grapple with for the next couple of decades. When I look at, for example, the availability of labor and delivery services, 50 years ago, there were probably 12 or 13 rural hospitals in communities that provided that type of care. That is down to 4 rural communities, which basically serve as rural hubs for labor and delivery services. And those include Ely, Fallon, Elko, and Winnemucca. And in some instances, those are not profitable service lines for those facilities. So they want to maintain and keep those services in their communities, but again, struggle with financial and legal liability issues that make that very difficult. I'm going to also mention policy and reimbursement change that are helping, again, if not driving additional demand, expanding who gets care and for how long. So we look at the growing complexity and acuity of pregnancies. Just a couple of things that I wanted to point out. Again, against the backdrop of declining birth rates is increasing complexity and volume of care required for those who are increasingly older when they present. And we're also seeing a number of comorbid conditions with that population, including familiar chronic disease, but also, again, importantly, indicators of prenatal, if not perinatal, mental health and substance use issues. The result of that is an increase in demand for more specialized care, and definitely an increase in demand for care coordination across those maternity care deserts. But at the end of the day, more frequent visits and consultations and additional screening and diagnostic issues. Due to low volume, as I pointed out earlier, workforce shortages and other issues that make the provision of labor and delivery and other obstetrical services in rural areas, we've seen again a growth of what are referred to as maternity care deserts. Good consequence of this, if you will, is that this has drawn considerable attention from federal agencies that we lean on in Nevada to help us with workforce and training. I'm going to close on a positive note later, but by just mentioning out, we have quite an expanding tool chest of measures that we can take as a state to address these workforce issues and the perinatal health workforce, and a substantial infusion of dollars through the Rural Health Transformation grant program. So I'm hoping that combination of need, urgency, and now the availability of dollars to address those workforce issues will see some important change in how we deal with these challenges. I finally want to, we think about demand drivers, mention the importance of Medicaid in this discussion, and concerns that I have about changes baked into the One Big Beautiful Bill Act. It's going to have important impacts on Medicaid and Medicaid spending in the state of Nevada. But it's interesting and important to point out that Medicaid currently finances a little over half of the births in Nevada, and that includes rural and frontier areas of the state. We've also seen some policy drivers at the state level, such as continuous postpartum eligibility, more recently doula reimbursement, community health worker reimbursement, and then some reimbursement bump. I never talked to a hospital administrator that doesn't remind me that that's oftentimes below cost, but it's critical to point out just the absolute importance of Nevada Medicaid in addressing maternal and child health issues, but also the ability of facilities to support that workforce. I want to shift now to issues of workforce supply. There's lots of gaps in this data. The data and workforce data that is collected by my office and team typically relies heavily on existing data sources such as licensure counts, employment projections from both the state and federal Bureau of Labor Statistics and so forth. Nonetheless, I think that what I'm able to do is provide evidence of a growing shortage of providers and practices. And I think it's need to thank individual providers and practices both in the same breath that provide OB care and perinatal healthcare services. A couple of things that concern me is even though we've made important steps or strides in increasing that workforce, a good number of folks in that workforce that the way I've defined it, particularly in nursing, are nearing retirement. So we're seeing a growth in demand just simply when we begin adjusting for the attrition of the existing workforce. I wanted to share something, and indulge me, I promise not to spend too much time on this, but a little wonky development from the federal government with respect to, again, an important and positive focus on maternity care, particularly in rural and remote areas, is the creation of a recent creation of a designation from the Health Resources and Services Administration to identify areas across the country at the county level, sub-county level, that have a shortage of maternity care health professionals and a corresponding high level of unmet need. If I make this presentation in 2 or 3 years, I'm going to be privy to some really great detailed data to inform policymaking in the state of Nevada. But what the data and the way they're collecting it are important is it's going to provide groups such as the PPC and other policymakers just a much more granular look at the scope and severity of these deserts and high areas of need. The reason the feds are doing this is it's going to importantly inform eligibility for programs such as the National Health Service Corps, the National Nursing Corps, and that's a good thing. It'll help Nevada address workforce needs through a very important federal funding source. What the way they are defining what is a maternity care target area is by looking at the female population, a subset of the overall total population, relative to maternity healthcare professionals, which they define as OBs and certified nurse midwives. They also are attempting to factor in the poverty level of the community, a good indicator of above average health and social needs, as well as the time and distance to the nearest source of maternity care. I mentioned earlier 4 rural hospitals that are kind of the remaining rural facilities that provide labor and delivery service. So it's to those rural hubs, if not Reno or Las Vegas. Also takes into account the fertility rate of the population. Again, they don't use the crude birth rate, but rather focus on the birth rate adjusted for the size of that female population in a given area, 15 to 44. And then, interestingly enough, and I think this will complement other presentations today, that index used to identify maternity care target areas has a pretty nuanced maternal health index that incorporates behavioral health indicators, prenatal care, and health-related issues such as diabetes and obesity. The good thing is is that this methodology builds on existing primary care and mental health professional shortage data. That's data we do have at the moment. So the next couple of slides will provide a glimpse at the nature and severity of primary care and mental health shortage areas. This map here, again, utilizing federal data on shortage areas, married to census and demographer data that we have here. What we try to do is update this at least on an annual basis, because in many respects it changes at the micro level. But in general, currently we have a little over 2 million residents, or about 65% of the state's population, that live currently in a primary care shortage area. That's includes both urban and rural areas of the state, but importantly, 12 of the state's 14 rural and frontier counties, the entire county is a primary care shortage area. This is another, unfortunately, similar story. When we updated this map last year, we found that a little over 3 million Nevadans, or about 9 in 10 individuals in the state, reside in a federally designated primary care HIPSA, and that includes all 14 rural and frontier counties. So again, when we're thinking about indicators that give us a better idea of both need and workforce capacity, the primary care and the mental health professional shortage areas provide us with a good glimpse of where to target our attention as policymakers and strategies to address those. I wanted to also just mention that our office for the last 5 or 6 years has tried to put numbers to those lousy rankings that we hear about continuously. I don't think it gives the PPC or any set of policymakers much to go on if we're 47th in this or 49th in this or that health workforce metric. And what we've tried to do is come up with estimates at both the industry and the occupational level to shed light on just how short we are when it comes to workforce. My glass half empty says this is a problem that's dogged us a long time. My glass half full take on this is that to the extent that we as a state are addressing these workforce deficits, we're also contributing to economic development and diversification. Many of the shortcomings in these workforce numbers are opportunities to expand and diversify our state's economy. When we look at, for example, ambulatory care and hospital care, those industries within the healthcare sector, it would take almost 11,000 new jobs in each one of those just to bring us up to the national average or the national metric there. So a good deal of work remains before us as a state. More importantly, and more germane to our discussion today on the perinatal healthcare workforce, is a couple of selected occupations. There's some missing here, and it's because I don't have data from the feds or the state on these, but I think this is a great illustration. I've just picked 8 positions from that earlier table on sample occupations that make up the workforce, and you can see the work that remains ahead of us. Just looking at the entire physician workforce, it would take 2,300 additional physicians just to bring us to the national average. Even more severe issues or shortages with the registered nurse workforce. Almost 5,000 additional nurses would be required. And if you, again, think back to that original definition of what makes up the perinatal health workforce, this includes labor and delivery nurses, antenatal and postnatal nurses, and NICU nurses, and the like. Equally important are some of the physician specialty areas: family medicine, OB-GYN, and pediatricians. Again, these are numbers that we need to bring us up to the national average. And I'd point out that that number of 80 OB-GYN physicians doesn't sound like a daunting number until you're until you're trying to work as we are up north in establishing an OB residency program that will produce 3 new OB-GYN physicians in 3 or 4 years, and that's a large undertaking. So again, by any measure with the available data we have, important workforce gaps in that perinatal workforce. I wanted to close because it seems like I'm closing a lot of presentations this day by highlighting concerns that I think I'm not alone in possessing with changes that are over the horizon with Medicaid program. And again, have you think about a program that now finances over half of the labor and deliveries and prenatal care in this state, and that is HR 1, which was signed into law on July 4th back in 2025. I don't want to necessarily get into the details of that, but focus on some of the provisions that I would argue are cynically going to be kicking in shortly after the 2026 election, and they have important implications for the state as a whole, insurance coverage and access in particular. But I think for your discussion today, the landscape will be changing if Congress doesn't address that. I'd also point out in a good respect, there are some good aspects of that legislation that are front loaded. I'll mention those in a minute. But again, overall, what a number of national health policy groups, such as the Commonwealth Fund, and even here in Nevada, we have some estimates of what's going to happen. These are some of the mechanisms. Again, I'm not going to get into the detail, but a combination of work requirements, eligibility determinations that will take place every 6 months instead of annually, and so forth. We are going to see, if not corrected, reduced Medicaid spending in the state of Nevada. Here's some of the projected impacts, one of which came from the Nevada Health Authority. I presume they're keeping a close eye on that estimate, and that estimate will change over time, but they're estimating that as many as 100,000 Nevadans, or about 12 to 13% of current Medicaid enrollees, could lose that coverage. Other disruptions are there. I mentioned providers in that last bullet. I think it's just important to remember that the big harm will come to those individuals who will lose access to care. They're formerly eligible for Medicaid coverage, but it's important to also say that reduced spending is going to hammer providers who over the past 15 years have seen a steady drop in the number of uninsured patients presenting to their facilities, but now stand to see a growth in uninsured and a drop in those with coverage. Here's a really good way to close, and that is I talked about front-loaded good things in the big beautiful bill and some concerns and reductions in spending down the road. I am absolutely bullish that the dollars that are going to come to the state of Nevada through that Rural Health Fund can address some of the workforce challenges that I've outlined briefly in my presentation today. I think those dollars, the state, to their credit, is earmarking about 40% of the $180 million we're going to receive each year for the next 5 years to workforce development. And we have a lot of good models or cases that work. My office was a recipient of a HRSA primary care enhancement grant. It was a fancy way of saying that we can use grant dollars, and have evidence here that we can enhance the capacity of rural family medicine physicians, PAs, nurse practitioners, to attend to prenatal care issues, labor and delivery issues, complicated pregnancies, and the like. They're not going to do it all. They're not going to be a substitute for hospitals with those services, but it's one way, I think, in rural and remote areas we can begin addressing those challenges. I'd also point out that the UNR School of Medicine, along with Renown, is going to be rolling out an OB residency program next July. But again, that is a long runway and a long ramp to what at the end of the day will be 3 new OB trained physicians in Nevada. There will be some rural rotations in there, which is a good thing. And I'll close with a little comedy because I think those issues can be addressed. They will be addressed, and policymakers will be paying attention to those in 2027 here. But I think that Nevada will be dependent on the actions or inactions of Congress over the next couple of years. And just would reiterate discussions I've heard from other states mirror ours, and that is a great deal of concern about the future of Medicaid over the next couple of years and what that might mean for the health workforce in our state. That would include, importantly, the perinatal health work. So with that, I am happy to take any questions the group might have.
Thank you, Dr. Packham. Any questions from folks, from commissioners? Commissioner Kirkpatrick?
Thank you. I just have one. I heard you talk a lot about the north and the rural area, and I know that we do some work in the south with UNR. So are we part of the dialogue? Because people forget that like Mesquite is very rural, Laughlin is very rural, and I can't seem to get anybody to, consider them because they just think that they're part of Clark County, but they're 100 miles from Clark County, right? So they're closer to other places.
Yeah, absolutely. I think it's been in the last year or two where Mesquite, which is a hospital that's doing quite well financially, had to drop their labor and delivery services. I think it was like in the last year or two, and that's a community that has a much older population on average. But I think it's important to point out that in a well-off community like Mesquite that has access to a wide range of hospital services, women are going to have to travel to St. George to take care of most of that care. And so these maternity care deserts are an equal opportunity issue in all corners of Nevada. I might have just mentioned Northern Nevada because I'm more familiar with that corner of the state.
No. I get that. And Madam Chair, just to follow up is like Logandale is 26 miles from Mesquite, and that is a high birth rate area. But even getting to Mesquite, and now there is no L&D there, they have to go all the way to St. George. And then so I just want to make sure that when we talk about rural areas that we take into consideration the rural areas within an urban core.
Right. And I would argue, I'm not privy to the financial books of any rural hospital, but in a couple of those communities that have been able to maintain labor and delivery and OB services, they have the luxury of net proceeds from mining tax. So they're not supporting that service line through operations, which is a very demanding task for any hospital, rural or urban. They have additional revenue that your typical rural hospital doesn't possess.
Dr. Walker?
Hi, thank you. That was a wonderful presentation. I was curious if in your research and preparation for this or in your experience, if you can speak to any of the reproductive health and preventative aspects that may also help facilitate this issue. We know that, the state's account for family planning, Title X programming, things like that provide valuable resources to prevent high-risk pregnancies. And then also provide financial and medical support for obtaining or achieving a healthy pregnancy. Do you have any statistics or information that you can provide along those lines?
I don't have any data like that, but I'm familiar with that. And so Again, I don't want to harp on HR1 too much, but that's another concern of mine is hits to family planning services that sometimes come through Medicaid, but other federal funding sources, and they're all under attack right now. I think some of that is in the rearview mirror and less of a concern to me. I was in DC a couple of weeks ago and pleased that all of the rural grants that my office oversees aren't in the crosshairs of Congress. A couple actually got funding bumps, but that we're now talking about fiscal year 27, and I'm guardedly optimistic that when we talk about budget in the next federal fiscal year, it won't be as heated and contentious. So, crossing my fingers. I didn't have a lot of data to share with you. I think some of the subsequent presentations might touch on that, though.
Thank you. Dr. Porath.
Yeah, thank you. Do we have any sense of when HRSA's work around the maternity care target areas will be done, those designations?
Well, they've been in various stages of comment for years now. It's driving us crazy. I do think there is an impetus to make that more than just a numbers or data crunching exercise, because I know HRSA wants to utilize those for, again, some of the things I mentioned, National Health Service Corps loan eligibility. I think they'd be very helpful to the state of Nevada. My office oversees the Nevada Health Service Corps, and I think it would influence how we direct some of those loan repayment dollars. So I'm eager for that to happen, and I think it will happen. 2025, we'll look back on that as a year in which politics kept a lot of the normal functioning and rulemaking and so forth at the federal level, slowed that down. So happy to report back to this group when some of those changes have been made.
Thank you. Dr. Chastain.
Thank you, Dr. Packham. You mentioned a significant closure of obstetric service lines in rural communities over time. And I guess my question is, as we focus on expanding workforce, do we even have the infrastructure for those individuals to, serve the communities, or do those service lines need to be stood up again in a more sustainable way?
Boy, I'm gonna get in trouble if I comment too much on that, on what we should do in a rural hospital. But if you're asking more of my opinion than anything necessarily grounded in experience, I would say there are other ways to approach things like prenatal care in rural area. The federal government has a great demonstration project that's in like its third or fourth year. It's called I know the acronyms. It's Rural Moms, but it's the Rural Maternal and Obstetrics Management Program. And what that program has attempted to do is work with rural communities that reside in those maternity care deserts, working with some of those rural hub type hospitals, typically larger PPS and not critical access hospitals that provide labor and delivery, but then fold in elements such as telemedicine and consultations, Project Echo type training and specialty care areas of perinatal health and the like. I think we're past the time in looking at that as a poor substitute for actually having labor and delivery and OB services, but a way to tackle those issues in rural and remote areas with the workforce that we do have. I think we can walk and chew gum, and that is continue to expand the supply of perinatal health providers. We're doing that in a small but mighty way with this new OB residency programs, but also be thinking in an innovative way to stretch or maximize the existing workforce, which that Rural Moms demonstration is beginning to do. I still think the Rural Health Transformation Program you will see some good proposal to address the very issues, and I hope that a year from now we can come back and speak to some of the early successes in the application of those dollars, because the dollars are staggering. It's there's dollars to actually move the needle on these that we've never had before as a state.
Thank you. Dr. Peterson.
Yeah, just over the past year, I know that we had a lot of discussions around workforce development in the presentations that we had at PPC. So I'm just wondering, do you have any sense of the loan repayment, opportunities that were available? Have they made an impact on some of this, the shortages that we're seeing here, or is it too early? Just wondering if that is a good incentive and if it's being utilized.
That's a phenomenal incentive, and I can speak more to the program that my office oversees. Since 1989, my office has submitted and successfully received every time we've submitted, which is a good thing, federal funding that then has to be matched with a state general fund or some type of match. Sometimes we get the match from the counties that are served by those facilities and not. And it's not a complicated strategy. You basically take federal and state dollars. So we have skin in the game, provide loan repayment to actually a different set of eligible occupations that the National Health Service Corps underwrites. And I would argue it is arguably the best retention measure that we have in our tool chest. I spoke with the hospital administrator in Ely a couple of months ago and was told that the 20 people that our program has supported over the last 30 years, 19 of the 20 have stayed in the community. We always wonder if I'm going to support somebody for 2 years, service agreement in exchange for loan forgiveness. Are they just going to bolt after that 2 years? And that is absolutely one of the best stories that one could have, that you not only complete your service agreement, you remain in that community. And I would argue if we could provide loan repayment for 3 or 4 or 5 years, that individual is more likely to purchase a home, fall in love, sink roots in a community, come to love that community. And we're seeing that in Ely and elsewhere. So those programs work. I think the treasurer's program's kind of in the early stages, but I would be guardedly optimistic that that's going to produce the same results. Unfortunately, with that rural health transformation program, the state has been given guidance from CMS that we can't do that. That's unfortunate. Not sure or clear what the rationale for that is, because again, what we see is those programs do a phenomenal job of retaining not only physicians, but a wide range of health professionals. Can't be enough dollars in that space is my mantra.
That's good. That's good to know. Thank you. And in your dollars that you have access to, are those being fully spent? Like you're getting adequate applications, and
we spend those.
I know sometimes almost, just getting that information out is
we spend those almost as quickly as we get them. We have we have no shortage of highly qualified applicants. What we're trying to do is coordinate again with the treasurer's office a little bit, so that if we're funding more nurses this year, more physicians, and he's got available dollars, we're trying to spend those dollars wisely. But I know of very few loan repayments programs across the country that don't have difficulty spending every penny of what they get. I wish we had more.
Yeah, thank you. That's great to hear that 19 of 20 are still in the community. That's wonderful.
Okay, I think we may have one more question, but we're going to need to continue to move forward with some of the other presentations to make sure we have enough time. Let's see.
Dr. Packham, is there a good way if other commissioners have questions, they can get in contact with you?
Yeah, so I'll put my contact information in the chat, and you can maybe follow up with an email as well. Happy to.
Thank you.
Thank you so much, Dr. Packham.
Yep.
Appreciate it. We'll move now, I think, to agenda item number 7.
Yep.
And I think we have Vicki Ives here with us.
Oh, good morning. Thank you, Chair Sexton and the commission. Vicki Ives with the Division of Public and Behavioral Health. I serve as a bureau chief for Child, Family, and Community Wellness. May I ask, is my slide showing okay on your all's end? Oh, excellent. Thank you. I was asked today and really appreciate the opportunity to speak with a focus on one of the federal awards that we receive at the Division of Public and Behavioral Health, the Nevada Title V Maternal and Child Health Block Grant Needs Assessment Process, with a particular focus on maternal, perinatal, and infant health, going over a little bit of the data, the priority needs that came out of that assessment, and system level gaps. So I'll jump right in. And we go, a little bit of a lag. It's just noting that the focus of DBPH is really on making everyone's life healthier, happier, longer, and safer is our mission. I'll just go through a little bit about how we're organized in relation to these programs, some background information on the Maternal and Child Health Block Grant, some of the indicators, go into the needs assessment, some of the priorities that came out of the priority setting process, and then highlight some of the maternal mortality review committee recommendations, which is a body our staff support. So we're located within the Department of Human Services, and then within the Bureau is a section for maternal, child, and adolescent health. And then just a quick sense of some of the programs within that section. So the Title V MCH program we'll be talking about today, but also the Pregnancy Risk Assessment Monitoring Program, certain maternal mortality and severe maternal morbidity prevention programs, hearing screening, critical congenital heart disease screening, the home visiting program, rape prevention, and some teen pregnancy prevention programs as well, and the Count for Family Planning that Dr. Walker mentioned earlier. Within the Title V program, there's a maternal and infant program, children with special health care needs, adolescent focused, epidemiology focused programs. The state systems development initiative is data focused, and then our rape prevention and education program has a touch point, as well as the key fiscal staff. And then I just wanted to note within the Bureau, the WIC program, the immunization program, chronic disease prevention, and health promotion, Office of Food Security, or some other programs co-located with maternal, child, and adolescent health section. Before diving into that, just wanted to highlight very briefly the key role of the WIC program and the home visiting and immunization programs as well for this particular population. So even though today is focused on this Title V Block Grant Needs Assessment, WIC serves around 53,000 participants. The largest group within that are children, serving those who are low income, nutritionally at risk. They're pregnant, breastfeeding, postpartum and non-breastfeeding, infants and children to age 5. Similarly, the home visiting program provides voluntary evidence-based support, and that is largely based on one federal grant. And really the intent of that program is to end preventable infant mortality, child abuse, support parenting skills, and connections to referrals. WIC similarly connects folks not only to breastfeeding support, nutritious foods, provides nutrition education, but also linkages to a myriad of needs that a family might have. Similar to the national average, we serve about 50% of those in the state who are eligible for WIC. We also have other programs that touch these populations, our community health nurses, substance use related programs like the Women's Set Aside that have a pregnancy focus in reducing substance use in pregnancy. Of course, our immunization program, public health preparedness, just to mention a few. So there are many Division of Public and Behavioral Health programs that touch this perinatal space. But focusing on the block grant today, we receive federal funding from the Health Resources and Services Administration to improve outcomes on specific domains. And those key domains per federal definition on this grant, it's women and maternal health, those of childbearing age and during pregnancy, perinatal infant health, child health, adolescents, and children with special health care needs, which just is very broadly defined, any child with larger than average needs. So that could be a mental health need, that could be a metabolic disorder, it could be poverty. It's very broad brush on that. In Nevada, the funds go to supporting enabling and population health services. So not direct services with this funding in terms of how it's utilized in Nevada, and it does have a match. I wanted to highlight the Maternal and Child Health Advisory Board is a board that we present, our quarterly updates as well as our annual updates. We talk about our application process. We present the needs assessment to that board. And just wanted to highlight, in case it's of interest, some areas that they're focusing on as of the last meeting they had earlier this month. Are really getting updates on the craniofacial clinic at UNLV, syphilis, congenital syphilis in particular, in primary and secondary syphilis data, measles and vaccination data, and then looking at an update from the Governor's Council on Developmental Disabilities in relation to Down syndrome and AB 116 of the 82nd session. So those are just some of their recent priorities in this space, in case it's of interest. Right. So I've got a bit of a lag, my apologies. So just briefly on the data, we receive annually federally available data, which is nice because it provides a US comp for Nevada rates. So it lags a little bit in time, but it's valuable to us because we can see how we're doing relative to the nation. So it really focuses on outcome measures and performance measures at the national level, and then states can also have their own measures. There are dashboards that both the Maternal Child Health Title V Block Grant publishes, as well as the Nevada Health Authority's Office of Analytics in this space, where there's quite a bit of data publicly available should it be helpful and of interest. And really just highlighting our needs assessment process is something that this grant requires, is done statewide every 5 years. And that's how the specific performance measures and outcome measures that the Nevada staff of this grant, what they'll be focusing on, and who we will fund with those funds to support moving the needle on those priorities. And the process utilizes many statewide quantitative and qualitative data sources and reports feed into that. This is a very busy slide, but just to kind of give you a gestalt view of really the way to interpret this is the scores are relative to the percentage points Nevada is doing better or worse than the national average with using this federally available data across many different indicators. And as you're all aware, we trend the red is that where we're lagging behind the national. And if it's exactly on the middle and there's no blue or red bar, that means we're right at the average. Just noting a few of these, like child mortality is a red bar on here. So most of these red bars indicate something negative, but some means we're performing technically better than the nation on a few of these measures. But just to give an overall sense, this is just going through a few data points that were highlighted during the needs assessment process or topics. This is just a screenshot of the MCH dashboard. You can see you can cross tab by urban, rural residents, maternal age, marital status, insurance, depending on how that federal data comes to us. This one is looking at prenatal care, and you can see Nevada is the blue line, US is the yellow. And you can see as of the last federally available data for those two data points, we were very close to the national level. And then looking at vital statistics data on prenatal care that begins in the first trimester, just highlighting some of the variability here with the highest percentages among those who are non-Hispanic Asian, and then the lowest percentages for first trimester care among non-Hispanic American Indian or Alaska Native. Postpartum checkup, you can see a real divergence. Again, Nevada is in the blue for 2023 data. Postpartum checkup within 12 weeks of giving birth, which is, a state and national priority really about the postpartum checkup and its importance in things like maternal mortality prevention and just opportunities to connect people to care, whether it's reproductive health care, mental health care, substance use treatment. Percent of infants who are ever breastfed. This is also 2023 data. This is from the National Vital Statistics System as well. And you can see on the blue, Nevada's a very divergent trend here. We're starting to trend up a little bit, but pretty far apart from the national. And then another important metric in this space is exclusive breastfeeding through of infants, toddlers who are breastfed exclusively for 6 months through 2 years. And again, you can see the blue line is divergent from the yellow. This is actually from PRAM's data. So we interpret it with caution. It's a statistically significant survey, but the federal threshold for the year represented here, 2023, was 50%, and Nevada was at a 40.5%. So just flagging that, but even given that caveat, just noting the non-Hispanic African American percent compared to white and Hispanic. Infant mortality. This shows again Nevada in the blue, so infant mortality per 1,000 live births. And then if you look on the right, the blue bars are Nevada and the yellow national. So you can see that while we are doing better on many of those bars in the national, if you look at American Indian or Alaska Native, we do exceed for 2020 to 2023 data, infant mortality rate per 1,000 live births. And maternal mortality rate, we'll talk about that a little more with more recent Nevada-specific data, but this shows you a comparison from 2019 to 2023. And then severe maternal morbidity data as well, just drawing your attention to the renal complications and sepsis being slightly higher than the national rate and then the others that where we're lower. So that's just a high-level overview. Again, a lot more data is available publicly through various dashboards if it's of interest to the committee. So briefly, this 5-year needs assessment for 2026 to 2030, really setting out some goals and objectives, the domains that were covered, and looking at how those priorities were set, which results in an action plan. We did a request for proposals and ended up hiring an entity called Alterum to help support in this process. Multilingual outreach was done on this to as broad of, it's really supposed to be statewide, and outreach is sustained and significant up to a year before we start the needs assessment. And then high level, we use a lot of epidemiological data. There are surveys, pushing them out through all kinds of open meeting law bodies, listservs, partner networks, coalitions, key informant interviews, focus groups, and then some community capacity assessment and priority setting process, all fed into this needs assessment process. And again, because it's Title V related, really using the framework of those domains that I highlighted earlier, and we'll see those in a minute. Lots of participation opportunities. The survey had around 226 respondents. The priority setting meeting where a lot of the key priorities were winnowed down into some top priorities, had about 60 participants, community listening sessions about 70. So just trying different modalities to get a wide range of voices. And then the priority setting process included community input and rankings, certain forms to rank priorities, and then the facilitators scoring those as a way to get to the priorities and how those top priorities were selected, divided out by domain. And there are a few universal performance measures that are a fairly new development for this federal award, but most of the measures are set by the state. With the state performance measures, most states, there are largely national measures that are utilized. So the outcomes of this in terms of this process, in blue, you can see the ones that are new. Those in black were existing priority measures coming out of the prior 5-year needs assessment. So the new measures were improving access to prenatal care and maternal health services, highlighting the postpartum visit with appropriate referrals, that those are happening and meeting best practice. Increasing access to affordable, nutritious foods among school-aged children, and increasing physical activity among that group as well. And then service and resource access for sexual health and reproductive health. And then the existing ones, you can see breastfeeding, safe sleep, reducing substance use, promotion of a medical home, and appropriate referrals and care for adolescents. So given the focus on maternal infant, just zeroing in on those and highlighting, we just went through them. I won't read them again, but these are the ones within that domain. Again, focusing on access to prenatal and maternity services, safe sleep, breastfeeding, postpartum visit, reduction of substance use, and access to sexual health, reproductive health resources. And then in the also within the needs assessment priorities, oh my goodness, it didn't go forward, excuse me. Here we go. We're looking at maternal health and women of childbearing age. The priority needs selected focused on mental health and substance use screening and referrals into prenatal care, access to prenatal and maternal health services. And that postpartum measure that I've mentioned a couple times now is one of those universal. So all the states and territories are all working on improving outcomes in this area. And then a state performance measure around receiving prenatal care beginning in the first trimester. The perinatal group, again, looking at the priority needs highlighted on the prior slides, performance measures related to ever breastfed and exclusive breastfeeding for 6 months was an area of focus, as with substance use in pregnancy, and specific safe sleep supporting national performance measures. Now, the focus of this, I know, is maternal and perinatal and infant, but because child starts at 0 on this grant, just wanted to highlight the food sufficiency in relation to this infant population would also be relevant, and then teen pregnancies, so as well on the child health domain. And same thing, children with special health care needs, again, starts at age 0. The medical home, another universal national performance measure, and honestly one that has been a difficult one for the program. We had this in the prior 5 years as well. Any ideas about making that more robust would be welcome. And then switching gears a little bit, just wanted to highlight the work of the Maternal Mortality Review Committee and some of their recommendations and where you can find them as you're looking at this space. The MMRC has 12 members are appointed by the Director's Office of DHS. There's CDC funding now that supports that. It's set in statute in terms of its scope. In Nevada, every death of a woman while pregnant or within 365 days postpartum is reviewed, and it's really focused on identifying how do we prevent maternal mortality and severe maternal morbidity and those associated disparities with that. There is a report that goes to the Legislative Council Bureau before every session, and that is posted publicly as well. This is just an infographic. Again, it's always really important to make sure folks are talking about the same thing. So pregnancy associated deaths are really regardless of cause within that 365 days. So while pregnant or within 365 days of the end of pregnancy. So it's a broader definition. Pregnancy related death is, again, while pregnant or within 1 year by any cause related to or aggravated by pregnancy. And then maternal death is specifically while pregnant or within 42 days of the end of pregnancy. And those are very, I was at a meeting the other week, and they said, you know, comparing them is like comparing apples to hedgehogs. Like you have to be very, very careful to identify what you're talking about. And I think sometimes how substance is talked about that sometimes gets blurred. But we can, the next slide will dive into that a little more. Just noting more recent data than this, like looking at national to US comps from 2019 to 2023 shows a very similar pattern to what's posted here. Nevada's for this more up-to-date time period is at 22.7 and the US is at 23.5. So again, we're still just slightly below national. And then if you look, this is a pattern that we see, especially, you know, in the Western states, but even nationally, just noting this postpartum period of 43 to 365 days in terms of pregnancy associated deaths of any cause, just drawing your attention to the 71% of deaths falling in that time frame, as opposed to pregnancy related deaths, which this is coming from a federal resource, so that please note the dates are slightly different. But just noting how those deaths fall more heavily in the postpartum period, and then by definition, maternal deaths there. And this highlights a few disparities, racial to ethnic disparities, geographic disparities that exist in Nevada. Again, just drawing attention to pregnancy associated deaths versus pregnancy related deaths on the right. In yellow boxes, highlighting 3.2 times higher rate for Black non-Hispanic persons on PRD than Hispanic persons. Also looking at, you know, Clark County specific data in terms of higher burden in both pregnancy associated and pregnancy related deaths. And lastly, up in the upper left, just looking at disparities in relation to pregnancy-associated deaths in Nevada. And you can see the ratios across different racial and ethnic groups. And it's important to note sometimes, data suppression can sometimes just to avoid identifiable data. This is actually 0 cases in this particular sense, but we just like to flag that when it's 0 as opposed to a data suppression issue. And then looking just real briefly at pregnancy-associated deaths from 2022 to 2023, 86% of these non-transport accidents, and we use CDC framing and in the forms that are used that the committee makes their determinations. 86% of those were related to drug overdoses for pregnancy-associated deaths. And then you can see the other categories as well here. And just noting there's some variability when you break it out geographically or you break it out by race and ethnicity as to what an individual group's leading causes are. So these are overall in the green figures, but just they vary when you break out regionally or by race and ethnicity in some cases. Pregnancy-related deaths, again, this is from the CDC data, specifically on pregnancy-related deaths, and is an older time period. But you can see a different pattern here with hemorrhage. Recent studies that have been reported have really highlighted a growth in the infection space as well, that CDC just in the last month has highlighted. And then lastly, this QR code, if you scan it, can take you to see the full suite of the recommendations of the Maternal Mortality Review Committee. The Perinatal Quality Collaborative is highlighted. They rank them per just kind of the CDC protocol. What is the level of their recommendation? Is it, small, large, giant? Is it at the systems level, community, provider level? So this is just a sampling. There are quite a few recommendations made by the MMRC that are available, highlighting, access to mental health, free medication, assisted substance use treatment, obesity counseling, referrals, warm handoffs with mental health, certain screenings, protocols around aspirin use and treating anemia in pregnancy. There's a really a rich set of recommendations that I would encourage you to check out, that the members of the MMRC, as well as there's a process in this report, even though the MMRC members review the cases, there's a really key role for the Nevada Minority Health and Equity Council also makes recommendations within that report per statute and through an open meeting law process. And just in closing, some opportunities that were highlighted at interim health that are specific to this perinatal space. The Perinatal Quality Collaborative being one of 2 states without one, as a real key need to be able to spread and scale the best evidence-based practices and really move data to outcomes is highlighted as a key need. Some opportunities to expand evidence-based home visiting and to be able to draw down the full complement of federal match that's available to expand those who are served by that program. Looking potentially at, can school-based services, support pregnant and parenting youth, pediatric specialist capacity. Those are just a few opportunity areas that were highlighted recently in case helpful. But with that, just thank you so much for the opportunity and happy to take any questions. Thank you.
Excellent. Thank you so much. It looks like we do have a couple questions, so we'll start with Dr. Walker.
I thank you, Vicki. That was a wonderful presentation. I think it's kind of remarkable to me that we're one of 2 states that are not participating in a perinatal quality collaborative. What would it take for us to participate in a PQC?
Thank you for that question. It's really variable if you look nationally. Some states go a statutory route, some states do not. Some states house them with a hospital association, some with a university, some with a freestanding entity, and some with the state. They're really variable. There was a budget element that ended up not getting passed that would have supported a PQC last session, and then the session before that as well, a bill that had dedicated state funding around a PQC. So it can be a statutory route or not, but I think there's some other experts on that on the call as well. But other states have found different pathways, and they range from being multi-million-dollar state-funded entities to, $300,000 a year entities. There's very variable in terms of funding and structure and pathway to develop them. But there have been numerous attempts, and it's been highlighted as an important need in the state in many spaces.
And if I could just follow up, and I just want to make sure I understand the role of a lot of the MMRCs, those maternal mortality review committees, really kind of get that root cause analysis, but many PQCs serve as that QI initiative to try and implement changes to prevent those root causes from happening again. Okay, thank you.
Yes, and consolidating, like there's a perinatal health initiative that's been doing, amazing work in the substance space. There's the patient safety bundles that not all hospitals statewide are participating in, like having an umbrella to pull and coordinate these together with subject matter experts. In many states, they might even have a bill draft request. But just moving the data and recommendations from, the fetal infant mortality review, the child death reviews, looking at the 1 and under, for just talking perinatal right now, like there's no one place to coordinate, look at all of that data and spread and scale rapid cycle quality improvement changes. That's just a huge benefit of a perinatal quality collaborative.
Thanks. Dr. Pora.
Hi, thanks, Vicki. Wondering if some of this Title V block grant funding could potentially be leveraged for increasing access for RSV protection. We have a problem in that right now only like 1 in 5 kids in Nevada is getting protected against RSV, and part of that is just the maternal vaccine is only available through a pharmacy right now, and is not. I've seen other states where they actually have leveraged the VFC program to make that available for mothers of children that are going to be eligible for VFC. So just wondering if there's anything around that we might be able to do.
Oh, thank you so much for the question. Yeah, I was surprised. I've been involved in 3 of these 5-year needs assessment processes, and I always make sure to engage every, immunization advocacy group and subject matter expert I can think of on that process. And it hasn't, in the past 3 at least, risen to a priority on immunizations. I can't say what we do have right now in the maternal RSV space. We get some limited state general funds to the Nevada State Immunization Program for the cocooning program, but we're able to do not just the Tdap and flu, but we can and do RSV can be purchased for maternal use under that cocooning program. That is available, and then of course VFC RSV for the infants. But currently Title V isn't, and currently Title V isn't doing direct services. I would also note account for family planning that was brought up earlier and served about almost 52,000 individuals in state fiscal year 24. So that has account for family planning and some contraceptive pieces, but it also can support immunizations for those that cannot otherwise afford them. So that's just another route for immunization access for those who can't otherwise afford it, or maybe they can't make the copay. So that is another source, which is a larger pot of general fund. But currently the cocooning program, and then our VFC doesn't allow for maternal use, but our cocooning program with the state funds does, if that's helpful. And I can share with Mr. Melov some information about that program and how folks access it, if that would be helpful.
Yeah, that'd be great.
Okay, will do. Thank you.
Excellent. Dr. Peterson?
Yeah, thank you. Vicki, can you help us understand what's the current lag time for the review of the MMRC cases?
So we currently have 2 part-time nurse abstractors, and we are we're closing out 2022 cases. We just got permission to hire another part-time nurse abstractor to speed up just our capacity for case abstraction. It's a really complex process. It includes, can include, if the mother had child protective services history for herself through their youth, for children and infants, criminal, hospital, mental health, provider records, getting quick turnaround from the providers on that record to have a complete set of records of what all's available, vital statistics, were they in WIC, were they on SNAP, were they on TANF, like just really rich set of data. But they're abstracting in 2021. We have all the cases through 2024. But it's just getting all of the information in, getting it abstracted, and getting it to the MMRC for review.
Is there a recommendation on where that should be?
It's variable. The older MMRCs tend to be more current. We're in a cohort of states with the funding. This state was doing this without funding, initially. And there are other states certainly in a similar year. But there's states that by statute, maybe they exclude motor vehicle related deaths or homicides, or they only do pregnancy related deaths. They're doing every case. So we're hiring additional staff to help with that process. Because we would like, much more current than that, and the MMRC is committed to that too, and they've changed recently how they're reviewing the cases, where they do breakouts and have leads, and that was really efficient. It resulted in 6 cases being fully reviewed and completed at the last meeting, as opposed to the normal 3 to 4. So yeah, lots of efforts on that front to make that more efficient.
Just one additional question, because there's really important information that does come out of that. How is that information being communicated to clinicians and the health systems to make sure that everybody's having access to know where they need to make interventions?
Yeah, so that is it's widely promoted, the legislative report that comes out every 2 years. We also have a public facing dashboard that has the Office of Analytics, does all the heavy lifting on that. That's updated frequently. That has both maternal mortality and severe maternal morbidity state data. It doesn't have that like national comps piece. So those are available. We promote it widely. We present. We make sure the MCHAB is aware. The open meeting law groups. It gets pushed out through, even our nutrition listservs. Ideally for many programs, whether it's patient safety bundles with AIM, MMRC, critical congenital heart disease and early hearing detection, we don't currently have staffing capacity to have someone going around like hospital to hospital, provider office, with a clinician to a clinician communication to better support that. And we have had that feedback where people are just like, you know, I know it's on your website and you're saying you're sharing it here, there, and elsewhere, but how come I've never heard of it, you know, in my practice? So that's something, if we can get this person, this new person at halftime, where our hope is to be able to bump that person to full-time and at least have part of their job in like traveling and community outreach of an RN going to other clinicians.
Is there maybe collaboration with the hospital association? Because that's an easy, you know, do you currently have that?
Oh, certainly. Yeah. They always get the report. We meet on occasion. It's usually centered, you know, centered on the maternal mortality piece. But yes, they've been an excellent partner from day one.
Okay. Thank you.
Thank you. No, it's an excellent point. Thank you.
Excellent. All right, we are going to continue to move through the agenda. Thank you so much, Vicki, for joining us and sharing that great information. Let's move on to agenda item number 8, which is also, is it also Vicki doing this one too?
She covered both,
it. Okay.
so we're on agenda item number 9.
Perfect. We're on 9 then. Thank you. And we'll have Dr. Woodard join us.
Hello, good morning. Give me 1 second and I'll pull up my slides. I also have 2 other co-presenters that are also joining me. So if they can also come on. Are you able to see my slides?
Yes,
wonderful. Great. Thank you so much for inviting us here this morning. Some difficulty moving my slides here. Let's see if I can get this to work. Here we go. Good morning, Chair Sexton and members of the committee. Thank you again for the opportunity to present on the Advancing Perinatal Behavioral Health Project today. My name is Stephanie Woodard. I am a licensed psychologist in the state of Nevada, also serve as a healthcare consultant and clinical associate professor at the University of Nevada, Reno in the School of Public Health. I previously served in the Department of Human Services as the senior advisor on behavioral health for several years. The last 6 of those years actually served as the behavioral health commissioner for the state. And so my vantage point and approach to this study was very broad and vast, just knowing how many different areas the perinatal behavioral health issues do touch. And throughout my career, I've had an opportunity to work with and on behalf of individuals in the state who are struggling with behavioral health conditions, primarily focused on improving our behavioral health system to meet those needs. And one of the priority populations that I have really focused on is pregnant and parenting women who are struggling with behavioral health issues, including mental health and substance use issues. This morning, I am joined by Muna Emasobum and Sarbian Sheni. They are co-authors of this report and are also recent MPH graduate students from the University of Nevada School of Public Health. This project was funded by Roseman University through a federal grant award through the Department of Human Services, Division of Public and Behavioral Health, the Bureau of Behavioral Health, Wellness, and Prevention. So just a little level setting before I get started. I would just want to take an opportunity to thank all of the state agencies whose guidance and expertise continuously strengthen this project. We worked with every state agency and program that we could get in contact with to really help to inform this project and to engage with them throughout. We also were able to really engage healthcare professionals, behavioral health providers, child welfare agencies who offer this compassionate care to women and families every day, despite the multitude of challenges and pressures from overwhelming needs and insufficient resources. And lastly, I want to express our deep gratitude for the women who shared their experiences with such strength, honesty, and trust. These were women who were actively in care for behavioral health conditions during the perinatal period. And we were really moved by their stories of resilience and inspired. We feel very honored to have an opportunity to elevate their voices through this work as well. A little bit about this study. For the past 10 years, Nevada has actually made considerable progress in perinatal behavioral health through efforts in healthcare policy, payment reform, funding opportunities, and program implementation. And yet, despite these efforts, undetected and unmet behavioral health conditions continue to have adverse impacts on pregnant people, parents, and their newborns. So as you just heard from Vicki Ives from DPBH, 86% of the non-transport accidents that have been found through the Maternal Mortality and Review Committee, 86 are related to overdose. So we know that we have a very significant impact on perinatal substance use. In addition to that, we also have quite a bit of data, and I would point you to a report that the Department of Human Services has provided on gestational exposure in utero, and they have done a very comprehensive evaluation of the health outcomes of infants that are exposed to substances in utero, and some of the implications for their families, including the increased rate of child welfare involvement for those families. There's been a full court press from a legislative standpoint to be able to implement some of these policies. But what we were really targeting in this study is what needs to be done to really implement on the ground and make sure that these policies are actually translating into increased quality of care and improved outcomes for mothers and infants. So we took a very broad brush. This project examined the intersections of healthcare, behavioral health, child welfare, infant and early childhood systems, with the goal of identifying barriers to care that need to be addressed in order for us to see those anticipated improved outcomes for perinatal women and their infants and families. I'll turn it over to Sarbian.
Thank you, Dr. Woodard. And thank you everyone for the opportunity to present on this report. So for the literature reviewer, how did we come about all of the things we got to find out at the course of this report? We reviewed policy documents, including MMRC reports, state documents, particularly the infant gestational outcome report that came out in 2024. And to add to what we did, we also conducted qualitative interviews, particularly 24 key informant interviews and 7 focus group discussions with about 100 individuals. And we also did a geographic mapping of women's health and behavioral health resources across the state using some of the data from the Office of Statewide Initiatives as well. It was a pleasure to listen to Dr. Packham's presentation. Next slide. And a key thing we set out to do with this report was to accurately reflect the perspectives of the groups that we spoke with, which included women in care, healthcare providers, payers, state health agencies. And as you can see reflected in some of these quotes, they did tell us some of the difficulties that they were facing with integrating behavioral health screening into maternal health services. And also on the part of women with lived experiences, they did talk about the difficulties that they faced disclosing behavioral health issues or substance use issues within the perinatal period. And Dr. Woodard will talk more about what we found, but this is qual data that reflects actually how people are experiencing the perinatal behavioral healthcare system across the state. So I'll hand over to Dr. Woodard.
Thank you, Sarbian. So a couple of quotes here that I just want to underscore because we pulled them out because they were really exemplary of a lot of the voices that we had heard throughout our engagement with individuals. For providers, we consistently heard from healthcare providers, be they primary care providers, OBGYNs, or even pediatricians, that there is a significant apprehension to screen for behavioral health conditions because there is no clear opportunity to do a warm handoff. And so while they recognize that screening for behavioral health conditions as part of a care episode is really critical, especially during the perinatal period, they need the referral system to be very straightforward and easy to engage. And so when we also talk to behavioral health providers in the community, many of them, even those that have specialty behavioral health services focused on perinatal behavioral health, there's not a really good connection between the providers who are doing the screening and making sure that there can be a warm handoff or a closed loop referral to behavioral health providers in the community. And so there is a real apprehension to screen. Providers also talked about some of the pressures that they have on the time that they have to be able to provide a number of comprehensive services during a single episode of care with a patient, and that behavioral health screening adds a whole other layer of complexity to be able to review positive screens and then to be able to sort of troubleshoot where that individual needs to go. So we recognize that not only do these issues need to be addressed and resolved at the provider level, but we also recognize that there are health systems that have different reinforcers that are in place that can make it very difficult for providers to actually provide comprehensive screening as part of an episode of care. Stigma is a theme that we heard consistently throughout our research. And when we talk to people, both people in care, but also people who provide care, including those that are involved in the child welfare system, stigma often is a barrier for women who are struggling with behavioral health conditions during pregnancy and postpartum to really be comfortable disclosing those issues. And when they have presented for care or they have been open and honest, many women reported not being received with a lot of care and compassion, and a lot of bias and judgment really stood in their way and made them feel that doing that kind of disclosure was really unsafe. And when you layer in the concern around potential child welfare involvement, you can understand the women often understand that there are pretty significant implications for that kind of disclosure. So I will summarize our key findings. I'm hoping Dylan is able to get you a copy of the full report. It is very extensive, so I recognize our presentation here is really going to be skimming the surface. I also want to just reiterate that if you had attended the Joint Interim Committee on Health and Human Services last week, you will have heard a very similar presentation in addition to other presentations that I think could be very helpful for doing things like framing the Perinatal Quality Collaborative. So I just want to point to some of the other subject matter experts that have really brought forward, I think, very profound and compelling testimony to support many of our findings and recommendations here. And you will hear some echoes of some of the previous presentations just from this morning, specifically focused on workforce and making sure that we are tying together a number of different initiatives across state agencies to really help to optimize those interventions. So not surprising, unmet perinatal behavioral health needs in Nevada continues to contribute to adverse outcomes for both mothers and their newborns. Again, these key findings are both looking at the data analytics that the state has been able to provide, national reports, as well as the qualitative data that we were able to gather as part of this study. And that subsequent to those unmet perinatal behavioral health needs, we have a number of adverse outcomes that include exposure to substances in utero, developmental needs, child welfare involvement, and increased maternal morbidity and mortality related to overdose and suicide. In addition, there have been several, as I mentioned before, legislative policy efforts and standards of care that have been able to be developed and pushed out into the healthcare systems. There's also been an allocation of funding to help to support the expansion of screening for behavioral health conditions. And it is important to note that there has been quite a bit of effort already done in this vein, but while it is necessary, it is not sufficient to get the outcomes that I think we are all seeking as a state. There are considerable barriers to providing integrated and coordinated behavioral health screening and treatment. This includes lack of access to adequate prenatal care, challenges with reimbursement for integrated care models. While there has been improvement in some reimbursement structures and policy related to integrated care models, there is still quite a bit of work to be done. Stigma continues to be a factor, and difficulties in accessing specialty care for behavioral health. As it relates to specialty care for perinatal behavioral health, it is limited and oftentimes very difficult to locate. Some states have actually moved to identifying or designated specialty behavioral health providers in the community so that they are easier to locate and that there is easier time connecting for care coordination and resources to support referrals. I'm having a difficult time advancing my slides. Sorry, I don't know what's going on here. There we go. There are multiple challenges with navigating multiple systems. Often these systems, we're talking about women who may have medical issues as well as behavioral health conditions, and then social determinants of health, concerns that also need to be addressed. And it becomes even more complicated if they're also interfacing with early childhood systems as well. So these systems oftentimes have unclear eligibility requirements, including social services to help to address food insecurity, housing, transportation, employment. And these just create additional barriers for pregnant and postpartum women who are seeking care and resources. The infant and early childhood systems, including pediatric healthcare, childcare, and developmental services, are often incredibly fragmented. There was actually a really nice study that was done last year by the Gwynn Center, specifically focused on the fragmentation of our early childhood systems and a need for a much more coordinated approach. This is because families often are integrated into multiple systems and really have a difficult time navigating their way through. As I mentioned, our study is also looking at child welfare because many families that have behavioral health issues, especially perinatal substance use, are at increased risk for involvement in the child welfare system. And as we engaged child welfare systems across the state, it became very clear that they really lack funding and resources to support the prevention of child welfare involvement. So really going upstream in providing support and wraparound services to families to help to stabilize them without having them enter into the child welfare system. And that includes support for family preservation and family reunification. So when mom and baby are separated through the child welfare system and child welfare involvement, really important for there to be as quick of an opportunity for safe reunification for that dyad. And so what ends up happening because of the lack of funding and resources for child welfare, we have high rates of child welfare involvement for families that are impacted by perinatal substance use. In addition, efforts to address sustainable funding, care quality and outcomes, and alignment of policies and best practices with standards of care have to be coordinated across state agencies. If you are aware of the multitude of state agencies that have any kind of touch point to maternal and child health, let alone perinatal behavioral health, you will see that there are many agencies and programs that are encompassed in a potential system. And so having the opportunity to bring those programs together for better alignment is something that we, and you'll see in our recommendations, continue to highlight as an opportunity for the state to explore. So I will turn it over to Muna, who will go over some of the data that I think echoes much of what you had heard from Dr. Packham earlier this morning.
Thank you. I want to thank the Commission for giving me the opportunity to present. Quickly, I'll be walking you through the geographical mapping we used just to highlight the perinatal behavioral health capacity in Nevada. This first map shows the OBGYN providers distribution in Nevada, and I want to acknowledge Dr. Packham and the Office of the Statewide Initiative at University of Nevada, Reno School of Medicine for making this data publicly available. This map illustrates providers per 100,000. And if you look, the darker shades are concentrated in the urban regions, which tend to have more providers. And the lighter shades highlights those areas which we have identified as maternal care deserts. Nevada statewide average is about 28 OBGYN providers per 100,000 residents. That's about one doctor for 3,571 persons, while the national average is at 33 per 100,000. The difference might appear a little bit not much, but it shows that it's masking a significant disparity when it comes to different counties across Nevada. Because only 4 counties in Nevada exceed the national average, which include Carson, Churchill, Lander, and Lincoln. And Lincoln also can be inflated because it's a very small population and just 2 providers will show that high proportion. So several counties do not have any OBGYN provider, including Douglas, Eukarya, Leon, Mineral, Nien, Pershing, and White Pines. And this place, like I said earlier, have been identified as maternal care deserts. Because when they seek care for professionals or specialties, they have to leave their area to different areas who have these providers. So even in the urban counties where providers are seen to be concentrated, resources remain constrained because the areas which, because they're not just serving their areas, they're serving areas who do not have these resources. Some people have to travel quite a distance. And this shows that this number does not reflect the urban burden that it's serving, because it includes those who are moving from the rural and frontier areas to the urban areas, increases the strain on the resources that exist in the urban areas. And when we overlay the hospitals, the health centers, and the clinic on the map, we can still show and the cluster of services around the urban regions, places like Clark County, Washoe County, or Carson. And this means that the rural and frontier families have to travel a distance to access perinatal behavioral health care. This workforce distribution impacts our ability to address perinatal behavioral health in Nevada. Next slide, please. Thank you. On this next one, we try to examine key perinatal health services across the states. This includes federal qualified health centers, certified community behavioral health clinics, women's set-aside treatments programs, and home visiting programs. And the distribution mirrors the provider distribution, showing a concentration around Las Vegas, around Reno, or Carson City, showing that glaring maternity care desert or the disparity of resource when you look at it across the counties in Nevada. So Las Vegas, Reno, and Carson, they have the highest concentration of services. However, in more than half of the counties in Nevada, there is no dedicated perinatal behavioral health service. There is no CCBHCs, no FQHCs. Counties like Douglas, Mineral, Esmeralda, Lincoln, Pershing, Humboldt, Eureka, Lander, and White Pines lack any dedicated perinatal behavioral health infrastructure, and families there have to travel a distance, and this means, excuse me, fragmented care and also significant delay when it comes to getting perinatal care. So this mapping demonstrates the challenges that Nevada is facing, not just workforce shortage, but a very obvious disparity when it comes to perinatal behavioral health services. Thank you.
So I'm going to move on to our recommendations. These are our high-level recommendations, and from these, there are actually sub-recommendations, many of which I will be going through because they directly relate to the scope and authority of the Patient Protection Commission, and I think would be relative for this group to hear. So the recommendations that we have in our study really serve as a call to action for state policymakers, providers, healthcare systems, payers and funders, state agencies, and advocates to prioritize maternal and child health, recognizing that healthy starts for newborns and families begin during a critical the perinatal period. The structural barriers contributing to current fragmented systems of care must be addressed through a coordinated and collaborative approach across multiple systems to reform existing policies and practices, align with best practices and implementation incentives, also to support families to thrive. Through the development of what we're calling an interconnected systems approach to perinatal behavioral health care, mental health and substance use disorder services can be integrated into broader systems of care, including early childhood systems, to address the complex needs of pregnant and postpartum women. The recommendations in this report are really written with the vision of having these recommendations really work in concert with one another, recognizing that the exploration and consideration of recommendations should be taken holistically as part of a larger system and comprehensive strategy. So you've heard a lot this morning already around some of the challenges that Nevada faces as it relates to maternal health care. These recommendations really do recognize that there is an internal maternal and infant system that is also in need of significant support and potential opportunities for growth and reform. And the recommendations here are really to ensure that behavioral health is a key consideration as the work is done on the larger maternal and infant systems. No longer, I think we all would agree that when we treat behavioral health as sort of an afterthought, it is much harder to then integrate behavioral health into those existing systems. So really a call to think of behavioral health as part of the comprehensive health system for high quality maternal and infant care. So high level, some of our recommendations include developing a perinatal behavioral health strategic plan across state agencies, including the Department of Human Services and the Nevada Health Authority, as part of the Children's Behavioral Health Transformation, and also connected to the managed care quality strategy. I want to highlight here that the Nevada Health Authority has done significant work both on focusing on children's behavioral health, but also the managed care quality strategy. The quality strategy does a number of different things, including really identifying the kinds of quality initiatives that need to be promoted in order for us to move the needle as a state on maternal and child health. So just really want to also demonstrate an appreciation for the efforts there. And the quality strategy does allow for a gathering of a lot of information and data for the state to really see how we are progressing in meeting some of the required demands and quality outcomes that we're hoping to see. Also to establish a regional level perinatal behavioral health treatment network to facilitate collaboration, communication, and resource sharing to support a continuity of care and navigation to recovery support services. We heard consistently that while we have lots of people in communities doing really phenomenal work, there is no way that they are currently collaborating or coordinating at a local level to ensure that they are really pulling together what we would consider the safety net of services to support moms and families that are struggling with perinatal behavioral health conditions. So really helping to bring people together at a local level so that there's a greater acknowledgement and collaboration between existing resources. In addition, to increase access to high quality, comprehensive, integrated perinatal behavioral health care across primary care, reproductive health settings, hospitals, and pediatric settings. We are lagging behind nationally with the rate of integration of behavioral health into primary care settings. And we do have some progressive policy that has been passed and is working to be implemented currently, but there still is a great need for increased opportunities for that level of integration. In addition, to increase access and availability to coordinated specialty perinatal behavioral health services that is evidence-based, culturally responsive, trauma-informed, and focused on dyad-centered care. Dyad-centered meaning mom and baby care, really seeing them as two individuals that come together in a very unique relationship. And when that relationship is really the center of care, care outcomes for both mom and baby improve significantly. And then top recommendation number 5, support families impacted by perinatal behavioral health issues to help them remain together and support infant and toddler development through the connected early childhood systems. So I'm going to touch on some of the key recommendations in our report that really, I think, speak on a deeper level to some of the recommendations that I had just gone over. So ensuring that we're connecting perinatal behavioral health initiatives to existing behavioral health and child welfare innovation efforts, as well as efforts focused on maternal and child care. This would allow us to align measures, standards of care, incentives, accountability and oversight, data reporting, public health surveillance, health information exchange, and the selection and implementation of evidence-based practices. I also want to call out here in recommendation 1.4 that many of these recommendations would actually fall under a perinatal quality collaborative. So while they are seen here as separate, they really do echo the structure that a perinatal quality collaborative could provide. And I think a worthy home for many of these recommendations to live. We could also look to create and implement a strategic plan to help to oversee the implementation and quality, continuous quality improvement. This helps us establish legislative priorities, like what is missing currently in the policy landscape that needs to be considered to continue to move the needle on some of these issues. Recommendation 2.2, to promote standards of care and evidence-based practices to enhance the quality of care and care coordination. There's been a lot of work to create patient safety bundles specifically focused on perinatal behavioral health care. And again, a perinatal quality collaborative would be the ideal setting for this recommendation to live. And then an opportunity to coordinate state agencies with existing consortia and committees, including this one, to ensure that there's really communication that supports some of those existing policies. We recommend that the state actually formally adopt the patient safety bundles that are focused on perinatal behavioral health, that we incentivize providers to screen for behavioral health care and connection to follow-up care through alternative payment structures such as rate enhancements or value-based contracting, and to reduce some of the administrative burden. We also see a great opportunity to create pathways to care to allow for providers to quickly refer warm handoffs and for closed loop referrals to establishing care coordination and care agreements. And this could also be done through contract requirements with managed care. One recommendation that I think many states have taken as part of a much larger strategy that I also want to highlight is the ability to establish and sustain a perinatal access line to connect providers who are on the front lines with consultation support for psychiatry and addiction medicine. We've heard about many of the workforce shortages that we have across healthcare and behavioral health. These kinds of access lines really do act as a provider extension, recognizing that we may not be able to have a behavioral health provider or a psychiatrist for that matter, or addiction medicine specialist in every primary care or pediatric or OBGYN setting, but this allows for those providers to have immediate access to consultation for cases that many times can be managed within that primary care or OB setting. We also are recommending that we continue to promote integrated health and behavioral health care delivery models. And this can be done by aligning policy and reimbursement structures, removing barriers for enrollment and billing for behavioral health services within medical settings. This also includes ensuring managed care organizations have structures in place to reimburse a range range of behavioral health integration models, including collaborative care models. We have a new collaborative care model that is available through Medicaid, but we also are hearing that there's a challenge with making sure that those services are reimbursable and that providers really know and understand how to maximize this model to continue to integrate behavioral health into their settings. We are recommending that there is an evaluation of the universal bundled rate for pregnancy and postpartum care. This is a policy that we identified early and often throughout our discussions through the study, because this policy has been identified as severely restricting access to community-based OB care and postpartum follow-up care through providers, including FQHCs and rural health clinics. With the bundled rate, if the individual who's providing prenatal care is not also the provider that is at the labor and delivery, those services are not reimbursed. And so currently we have providers, including our FQHCs, that are ready, willing, and able to provide some OB care, but are not able to currently be reimbursed for those services. Also, the opportunity to create a central repository of really highly high quality and reliable information that providers can use for patient to provider communication. There's a lot of really not high quality information out there. One of the issues that came up consistently was the risks of cannabis use during pregnancy and in the postpartum period. And so making sure that providers know where they can find this repository of high quality information to help with patient education. Enhance workforce competencies in perinatal behavioral health and integrated care delivery by infusing some curriculum into pre-service behavioral health specialties and internships, also medical and nursing education, residencies, and fellowships. These are models that when they are taught in pre-service education can easily be translated into clinical practice as people move into communities to practice, but they really do need to be trained in them upfront. And then to promote hospital-based dyadic care, including Eat, Sleep, and Console for the management of newborns with NAS. This includes the opportunity to evaluate the utilization of neonatal intensive care unit admissions for medical necessity for newborns and monitoring for withdrawal symptoms. We heard pretty consistently that babies are being seen in the NICU when they have only been flagged for a risk of withdrawal, not actually exhibiting withdrawal symptoms, which leads to a separation of mom and baby. And we believe that there may be some opportunities for supporting that more hospital-based dyadic care through Eat, Sleep, and Console, keeping mom and baby together. And then to support improvements of care through quality and outcome measures through the Hospital Quality Collaborative to reduce unnecessary NICU admissions and increased costs of care. Just a couple more I'm going to highlight, and then I will pause for some questions. Enhance workforce competencies through training and evidence-based practices and standards of care in the assessment, treatment, and recovery support to include level of care determinations, comprehensive treatment, and family care planning. There's a lot of opportunity, I think, to elevate the standards of care for specialty behavioral health in our state. And then Vicki had just presented on the MMRC, establish a rapid review process for the MMRC to ensure data and information are available as a public health surveillance tool to track causes for maternal morbidity and mortality, turning them into actual actionable prevention solutions. And she had already mentioned that they're looking to find other ways to address some of the backlog in some of their reviews. So with that, in the remainder of the presentation is the compilation of all of the recommendations from our report, but I will stop sharing my screen now and turn it back over to you, Chair.
Thank you so much, Dr. Woodard and team. Appreciate you guys. Are there any questions from the group? Dr. Chastain.
Yeah, thank you for this great presentation. I know you mentioned that there are still some policy barriers to reimbursement for integrated care models. I was wondering if you could describe with any specificity what those barriers are.
Thank you. There have been efforts to address this by policy. I think the biggest challenge that we're seeing is the support for implementation. Integrated care models, oftentimes for practices that are not used to using them, feel like kind of an insurmountable feat to begin to do the work to bring behavioral health and primary care, OB, and pediatrics together. And so this is where I think a focus on the support for implementation and high quality implementation is really critical. There have been barriers in the past that I believe are consistently being addressed. So the COM-C model is one example that we now have policy, but as we were going into provider organizations, we consistently heard people were not aware that the model was reimbursable. They didn't know how to implement it, and they really needed support into figuring out how this was going to impact potential work streams and clinical flow so that they could be able to implement. So this is where I think that we see a pretty significant gap really across the board, where we can be really progressive in policy, but don't have the support for implementation. And so those policies tend to sit without real opportunity for optimization.
Dr. Peterson. I think you may be on mute.
I am talking to myself. Thank you. I was just actually going to ask if we could maybe have a presentation on that managed care quality strategy. And I apologize if that's like already on the agenda, Dylan, or if that's even in your presentation that you have next. But I think just understanding, Dr. Woodard referenced how helpful that has been and that she thinks that's a really wonderful thing. So if we can maybe better understand that, I think it would be helpful.
Certainly. We'll have Nevada Medicaid speaking at the next meeting.
Okay.
Excellent. Appreciate all that you guys have brought together there in that presentation. Thanks so much again, Dr. Woodard. And then I think with no other questions, we'll continue to move forward. And I think, Dylan, you have item number 10 on the agenda, yeah?
So I got muted. Can everybody see my screen?
Yes.
Perfect. And thank you. And before we begin, I just want to note that the findings that I'm sharing today come from an ongoing exploratory mixed methods study examining some of the maternal and infant health in Nevada Medicaid. This full analysis is still progressing. However, given the commission's focus on perinatal health this interim, we felt it was important to share the findings that helped frame some of the current landscape and some of the structural patterns we're observing. And all the results today reflect some of the completed qualitative and quantitative data to date and are intended to kind of inform this discussion. So today I'll just begin with a brief introduction and context, and much of what I'll talk about has already been kind of discussed, and then I'll walk through kind of the study methods at a high level, and from there we'll review some of those key quantitative and qualitative findings, including different things like population characteristics of Medicaid, care utilization patterns, and themes from different stakeholder interviews. And then we'll close with a discussion of what these patterns might suggest. So as we've heard throughout the meeting today, Nevada continues to rank among the lowest performing states on some of these perinatal health indicators. And despite meaningful progress and growing statewide attention, the outcomes for moms and babies remain some of the worst in the nation. And Medicaid finances approximately half of all births in Nevada, making it one of the more powerful levers available to influence system design. But improving those outcomes requires more than just knowing where we rank, but understanding what are the factors that are shaping whether these families are receiving timely, effective care. And the purpose of this study is intended to not only explore what is happening, but why some of those care patterns and engagement may look the way that they do. So this is an exploratory mixed method study combining some of those qualitative and quantitative analyses. On the qualitative side, we conducted key informant interviews with clinicians, hospital leaders, managed care representatives, different subject matter experts and state leadership, and we also conducted a focus group with mothers in Nevada Medicaid. The interviews explored different barriers and facilitators to care and used a thematic analysis to identify different recurring patterns, particularly related to access, coordination, and system navigation. On the quantitative side, we conducted a retrospective analysis of about 33,000 Medicaid covered births in Nevada between 2022 and 2023. The sample included births with successfully linked Medicaid claims, enrollment, and vital statistics data, and examined population characteristics, social, clinical risk factors, and prenatal care utilization patterns, and then used as a regression model to identify some system-level predictors of prenatal care engagement. And again, I want to preface this. This study cannot tell us what the exact mechanisms or any differences or whether one factor directly causes another, as well as some of the full impact of some of the unmeasured variables. But it does help us identify where patterns are the strongest and what structural drivers might be influencing care. So moving into some of the qualitative themes, 5 consistent themes emerged. They relate to awareness and navigation of services, behavioral health integration, access to care, care coordination, and regional variation, and how the system operates. And I'll walk through each of these in a little bit more detail. So in interviews, stakeholders consistently discuss the challenges of navigating the system from both a patient and provider perspective, describing limited awareness of covered benefits, referral pathways, and plan-specific services. Variation across health plans was said to create confusion, particularly for providers serving patients across multiple plans. Patients, particularly first-time mothers or those with limited health literacy, have challenges with things like enrollment, renewals, and understanding how to access some of those available supports. And several stakeholders noted that families often learned about those services through informal word of mouth rather than just a structured system. And taken together, they kind of suggest that awareness and navigation barriers are contributing to misconnections and uneven access to care, particularly for the most vulnerable populations. And again, consistent with other statewide studies, stakeholders described ongoing challenges in behavioral health integration. I won't speak to this too much as we've had it explained more thoroughly earlier, but the themes included variability in things like screening practices, limited perinatal, specific treatment capacity and coordination gaps, as well as stigma and fear, which were also noted as factors that may influence disclosure and engagement in care. And given pregnancy is a critical window for intervention, the findings kind of reinforce what we've heard and the importance of structured and consistent integration within perinatal care. Within access to care, stakeholders describe challenges that extend beyond just the clinical availability. Workforce shortages, as we've heard, particularly in obstetrics, pediatrics, and behavioral health, were cited as ongoing constraints. Gaps in Medicaid participation in some areas may also affect timely access. Patients face practical barriers, including things like work schedules, transportation, childcare, housing instability, all of which can influence how they engage in care. Administrative processes, including enrollment timing and eligibility continuity, may also affect some of that connection to prenatal care. Finally, those broader workforce recruitment and retention dynamics, including things like reimbursement levels, cost of living, and the overall kind of policy climate, were described as shaping some of that long-term system capacity. And together, they kind of illustrate that access is influenced not only by those clinical characteristics, but by workforce supply and broader social and administrative conditions. They also describe coordination challenges that kind of reflect some of that system complexity. Care spans multiple entities from providers, hospitals, MCOs, community partners, the state, each with different distinct processes, referral pathways, and coordination roles that aren't always consistently defined, and the way they communicate those vary. As a result, patients may have to navigate multiple systems at once, and it just kind of suggests opportunities for clearer alignment and consistent information flow across the system. Then stakeholders also emphasize that perinatal care operates within very different regional contexts. Things like capacity, market structure, and different collaboration dynamics vary across the different regions of the state. Rural and frontier communities often face those geographic barriers, including long travel distances for maternity services, and these shape how care is delivered, and that strategies may need to account for those regional variations rather than relying on a uniform statewide approach for some initiatives. Shifting now into some of the quantitative findings, this slide provides some context on the Medicaid population represented in this analysis. You'll see that mothers are relatively young with a median age of 28 and more than half under the age of 30. The population is racially and ethnically diverse, with nearly half identifying as Hispanic or Latino. Most births occurred in Clark County, though more than 8% are in rural and frontier communities, which, as discussed a little bit earlier, operate within those different system structures. Then the majority are enrolled in managed care. Those 1 in 5 are in fee-for-service. And finally, nearly 2/3 of the mothers have a high school education or less, which is important when considering some of the earlier discussion around navigation and administrative complexity. But the demographic context helps kind of frame the care utilization and engagement patterns that will follow. The map here reflects the Social and Economic Vulnerability Index, or SEVI, that we developed for the purposes of this study. SEVI is a zip code level measure designed to capture neighborhood level social and economic conditions that may influence access to care and care navigation. SEVI is used as a proxy to assess underlying social and economic risk factors. It's constructed using the American Community Survey data and includes indicators related to income, poverty, employment, education, insurance coverage, housing stability, transportation access, and digital connectivity. Each zip code in Nevada was scored relative to others in the state on a scale of 0 to 100, with 100 being the most vulnerable communities, and that's in dark blue on your screen. In the later models, these were further categorized into quintiles so that we could compare that kind of continuum, with quintile 5 representing the most vulnerable for the purposes of the model. This kind of allows us to examine those perinatal outcomes not only by those individual characteristics, but also kind of the broader context in which these families are living. In addition to neighborhood level disadvantage, we also examined some of the household contexts. Most mothers in the cohort were already raising young children, which may influence time availability, childcare logistics, and different scheduling flexibilities. And many mothers reported only themselves in the household, suggesting that there could be some limited in-home support, as well as behavioral health risk factors that were also prevalent in the data. However, these are self-reported and risks are likely underreported relative to the true prevalence. This kind of reflects the broader social and household realities in which some of the prenatal care occurs in Nevada. And then within the analysis, we kind of observed high rates of chronic medical conditions and pregnancy-related complications, indicating elevated clinical complexity in this population. To contextualize these findings, we also reference data from the MMRC and other data provided by the Office of Analytics. Our study doesn't directly analyze mortality events in detail. However, the MMRC data show that Medicaid-covered mothers experience more severe outcomes relative to the overall Nevada population. And pregnancy-associated death, while it is rare, rates are higher among Medicaid beneficiaries. And substance use is one of those leading causes of death. We included this external context to kind of help frame, again, that this is a broader risk environment in which these pregnancies are occurring. So then when we look at some of those risks and how they sometimes impact outcomes, we can see here that the rates of preterm birth and low birth weight, which are elevated within the Medicaid population, with preterm births being at 12.3% and low birth weight being at 10.8%. This analysis doesn't attribute any causation, just it helps reinforce that many of the births in this cohort are happening within that higher risk context and underscore the importance of early engagement and coordinated care throughout pregnancy that in this next slide, we'll see that isn't always happening. Only 65.5% of Medicaid covered mothers received early and adequate prenatal care. This is meaningfully below the national average and below the Healthy People 2030 target. Let me explain a little bit about what early and adequate prenatal care is. It's early within the first trimester, and then adequate being the appropriate number of visits based on gestational age. Earlier, we just heard about early prenatal care. This is combining some of those a little bit more richer data. Postpartum visit rates were also low, but it's important to note that there are reporting gaps, particularly in this type of data, which may result in some of that undercounting. Even accounting for that and some of the data we heard earlier, the engagement appears to be much lower than we'd like. Taken together, these kind of suggest that a substantial share of the mothers on Medicaid are not consistently receiving timely care. And then this slide shows some of the factors that might be statistically associated with receiving early and adequate prenatal care. We used a multivariable logistic regression model. In plain terms, that means we examine many factors at the same time, such as age, education, race, ethnicity, neighborhood vulnerability, or our SEVI, in this it's called neighborhood disadvantage, and region to understand which factors remained independently associated with prenatal care engagement. Logistic regression does not tell us why something happens or prove causation, but it does estimate the likelihood of an outcome in this population, and in this case, receiving early and adequate prenatal care, while holding all of those other factors constant. The bars shown here represent the relative likelihood of receiving adequate care compared to a reference group. So, for example, Clark County is a reference group in region. The red bars for Washoe, rural, and frontier areas show lower likelihood relative to Clark County. For neighborhood disadvantage, the gradient shows progressively lower likelihood as vulnerability increases. And for education, mothers with less than a high school education are less likely to receive adequate care compared to those with a high school degree, while higher education is associated with greater likelihood of adequate prenatal care. And we can see these further in race ethnicity, where there are persistent disparities that we've seen earlier in the data as well. And importantly, these associations persist even after accounting for all those other variables that are in this model. So moving on a little bit to our discussion, and again, I just want to preface this, it's not my role to provide any recommendations, and this is just an exploratory study, and this discussion won't cover all of the factors that might be impacting these patterns, but I want to begin by discussing a few areas that may be opportunities when reviewing the data and in our conversations with the SMEs that contributed in this study. It's important to situate all of these findings within Nevada's workforce environment. We've heard this all before, but Nevada faces persistent shortages. 47% of Nevada counties are maternal care deserts, and these capacity constraints shape access in different ways across the state. High volume urban centers may face strain related to demand and panel size, while rural and frontier areas face those geographic access limitations. And workforce capacity influences not only whether care is available, but also how consistently it can be delivered, including appointment availability, follow-up, referral timelines, and coordination. As a result, all of these findings should be interpreted within this broader system context. The data shows pretty clear engagement gaps. We see disparities by education, neighborhood vulnerability, and regional differences that persist. In a complex health system, navigating care may require a high level of health and administrative literacy. And these findings align with what we heard in the interviews, that families and providers often experience the system as very difficult to navigate. And again, this doesn't establish causation, but the convergence of the data does suggest that this complexity may contribute to these uneven care patterns, particularly among the most vulnerable populations, and reinforces the importance of examining not only access, but how accessible the system is to the people that it is supposed to serve. And then finally, I also want to discuss, and it was touched on a little bit earlier, about how payment structure can impact engagement. Perinatal care in Nevada is largely financed through legacy or traditional payment models, including things like the bundled payment and per diem reimbursements. Payment structure influences how limited visit time is prioritized and how coordination efforts are supported. Bundled models may not consistently account for the additional time and infrastructure required for some of that care coordination, behavioral health integration, or high-risk patient management. Payment design and accountability mechanisms and data infrastructure are all very closely linked. And when aligned, they can reinforce some of the different desired care patterns, but when they're misaligned, they can contribute to variation in how these services are delivered. Payment models can also influence those utilization patterns across things like prenatal care. Sorry, my light is on a motion sensor. Payment models can also influence utilization patterns across things like prenatal care, labor and delivery, postpartum care, and NICU use. And the key point is not that any single model is inherently flawed, but the payment structure shapes behavior, and alignment matters when aiming to improve outcomes. And in later meetings, we'll hear about how some of these areas are being addressed. And that brings me to any questions you all might have.
Any questions, commissioners? Thank you so much for that information and looking so broadly. Appreciate that. Looks like no questions at this time.
Sounds good.
Thank you, though. Appreciate it. All right, public comment.
That moves us on to public comment. At first, I just want to share that we're soliciting policy recommendations, and you can fill out the form that's linked here to the side and fill out information for possible consideration by the PPC. And we ask that recommendations be submitted by April 1st to allow our staff to put together that information. And we will also follow up with a message on the listserv with the link and further information. So the item on the agenda offers an opportunity for public comment. No action may be taken upon a matter raised under the public comment period unless the matter itself has been specifically included on an agenda as an action item. To provide public comment telephonically, you may join the meeting by dialing 775-321-6111. And when prompted to provide the meeting ID, enter 981-401-478#. Please press *5 to raise your hand during the public comment period to provide your comments. Comments will be limited to 3 minutes per person. Persons making comments will be asked to begin by stating their name for the record and spelling their last name. If you wish to provide public comment and joining by phone, please press *5 to raise your hand. And if joined by the computer, please use the raise hand icon at the top of the screen. Chair, I see no one wishing to make public comment at this time.
Okay, thank you for that. Would just also encourage any of those of you that are on, please participate in the recommendation link and share that broadly with others who you feel might have great input for us to hear from. I think we appreciate all that feedback and certainly will be reviewing it and taking a look at it. So also want to just thank again all the presenters. I know a lot of time and energy goes into pulling all of that information together and being so prepared, and you guys did a tremendous job of providing great information to us today. So thank you for taking the time to do that. And I think at this time, I'll just say thank you for all those who attended, and the meeting is now adjourned. Appreciate it.
Thank you very much.